Okay, good morning, everybody, and welcome to our final installment of the Summer Series Grand Rounds. It's one of those markers of the end of summer is when the Summer Series ends, but today we are very fortunate to have Dr. John Vella with us. We're going to have a nephrology talk. So Dr. Vella is a graduate of the Royal College of Surgeons in Ireland. Can't hear me? Sorry.
I don't know why it's not.
Recording in progress.
Test. Okay, good morning, everybody, and welcome to Medical Grand Rounds. This is our final installment of the Summer Series. We're very fortunate to have Dr. John Vella here today from the Division of Nephrology. He's a graduate of the Royal College of Surgeons in Ireland, did his internship and residency at Beaumont Hospital in Dublin and also Boston City Hospital. He did his nephrology fellowship at the combined program with Brigham and Women's and Mass General, and he is currently the director of the Nephrology and Transplantation program here at Maine Medical Center and the associate medical director for the new Maine Medical Partners Nephrology Group. So Dr. Vella is going to update us on kidney transplant and take it away.
So thanks for that kind introduction. It's good to see people in person. I think we all have a degree of Zoom fatigue. So nice to see some familiar faces in the audience. So my brief today is to provide a brief update on kidney transplantation. And when thinking about how to give a talk to a general audience, I always kind of struggle a little bit with trying to avoid getting too far into the weeds on any one particular topic, but really try to provide an overview as to where we are. So I'm going to approach this from the perspective of policy, from the perspective of outcomes and quality. And we'll hit on a few specific points as it pertains to immunosuppression and complications. But really this is an overview to give this group a sense as to how are we doing in transplantation today. In terms of disclosures, I don't really have any. I am continue to have editorial responsibilities for up to date. We do have NIH funding for a kidney donor outcome consortium, which has been very successful, by the way, in doing living donor research. And I don't have any other pharma contracts to disclose. This does give me an opportunity to brag a little bit about our program. Recently, U.S. News and World Report did recognize Maine Medical Center nephrology as providing excellent care in the field of kidney failure. Not sure what the metrics were that they chose. It's not really very clear from their publication. However, when praise is coming our way, we'll always take it. So I'm going to start by talking a little bit about recent major changes in organ allocation. We'll review some of the data from the Scientific Registry of Transplant Recipients pertaining to outcomes. And there's a few novel findings in there that are positive and are worthy of sharing. We'll talk a little bit about the way that Health and Human Services is viewing end-stage renal disease management, and I mentioned complications and some of our local quality initiatives. And so starting with kidney allocation, the way that transplantation is governed in the United States has not changed over many decades. Health and Human Services operate something called the Organ Procurement and Transplant Network, which is this unique public-private relationship that links transplant professionals, transplant recipients, families, and donors. And the OPTN is actually managed by an independent, not-for-profit, non-governmental organization called UNOS, or the United Network for Organ Sharing. So UNOS has a contract to manage the OPTN. UNOS mandates policy on all matters pertaining to organ procurement, whether it's living donation, deceased donation, transplantation itself, and to some extent, post-transplant management and outcomes. And it also is very much involved in how, particularly deceased organ donors are distributed. And this is a fundamental issue because, of course, every transplant program wants to get as many organs as they can get for transplant purposes so that they can maximize care to their patients. However, one of the core things is, you know, when there is a deceased donor, whose resource is that? Is that a local resource? Is that a national resource? And so various kidney allocation policies have grown and evolved over time. Starting in the very earliest days, back in Boston, there was a group called the Inter-Hospital Transplant Consortium that met periodically to talk about how deceased donor organs were shared within the greater Boston area. And that ultimately grew over time into regional initiatives. And subsequently, UNOS divided up the country into 11 separate regions. We were UNOS Region 1. We still are UNOS Region 1. And the initial formalization of organ sharing policy was known as the Burdick Plan. And Burdick was the Secretary of Health and Human Services, a transplanter. And the Burdick Plan incorporated some very core principles. On the top right-hand side of the slide, some of the core principles that have been maintained over time are that certain kidneys were always going to be allocated to people with the greatest need. So, for example, kids, if you've got a child, i.e. An individual younger than 18 years of age in need of a transplant, clearly, for all sorts of reasons, including potential for growth after transplantation, getting that person transplanted quickly makes a lot of sense. Similarly, if somebody is in need of a liver and kidney transplant or a heart and kidney transplant, then the kidney would be allocated with the so-called life-saving organ. So some of these principles have been maintained through the various iterations of organ allocation policy. So the Burdick Plan really focused on a couple of ethical principles, really trying to balance equity versus utility. So equity means that, well, you want to have everybody get a fair shot at this, but also you want to have some way of allocating organs that are going to last longer. And so clearly younger donor kidneys are going to last longer than older donor kidneys. Better matched kidneys are going to last longer than poorer matched kidneys. The problem was that in this construct, there was a lot of regional variation, a lot of local regional rules, and it meant that we really didn't, in fact, have a national policy. And so ultimately, DHS said, look, we got to sweep away all of this variability. And this led to the second major implementation of the Kidney Allocation Plan in 2014. I'm calling this CAS, Kidney Allocation System 2.0. And so this now introduced a few new concepts, one of which was the idea of a kidney donor profile index. And it's a numeric descriptor of organ quality, so that the best quality kidneys, so the kidneys from the youngest donors with the best function, that donors don't have things like diabetes and hypertension, those kidneys would have a lower KDPI. And if you look at the graph, what the graph shows is KDPI and outcomes. And so the best kidneys last the longest. As the KDPI goes up, the graft projected survival goes down. And there really is a kind of a sharper drop-off when that KDPI is more than 85. And I'm belaboring this point because I'll be referring back to this in a later slide. CAS 2.0 also introduced the concept of estimated post-transplant survival. Not so much to say that if you know the age and gender and various other biometric characteristics of a recipient, that you can predict how long they're going to last, but you can't put people into quintiles. And so in this construct, people with the longest estimated post-transplant survival, i.e. children and young adults, would then be preferentially allocated the very best quality kidneys as evidenced by the lowest KDPI. And so that's what happened in 2014. Great, you say. The problem was this still did not really address the problem with regional access to transplantation and regional rules. And we're now into CAS 3.0, which started in March of this year. This was hotly contested. There were various transplant programs actually took UNOS to court on this. Again, transplanters are very territorial, and there was big concern that individual programs and regions would have lesser access. By the way, historically within our region, we've always been a very high-performing location in terms of the numbers of kidneys that we're procuring and transplanting, and also in terms of outcomes. And so in a nutshell, what UNOS has done is to eliminate these donor service areas. And now they're saying, okay, if a kidney is procured, then that kidney should be allocated within a 250 nautical mile radius of the procurement hospital. And you can see the map, and you can see, various programs and where those kidneys could be preferentially allocated. And basically, the closer you are to the donor hospital, the closer the patient is to the donor hospital, the more points they're going to get and the more likely they are to receive that kidney. So what does that look like for us? So we're a smaller program. Within Maine, we have two major organ procurement institutions. That is here and Eastern Maine Medical Center in Bangor. There are a few other smaller hospitals that occasionally do organ donors, but those are in the single digits. And when if we have a kidney that is, for example, procured now in Portland, then when you draw the circle around the 250 nautical miles, you can see on the map that we are now looking to have to share kidneys with a much broader area that includes huge urban metropolitan centers, not just Boston anymore. We've always been competing against Boston, but now we're also competing against Hartford and New York and New Jersey. So that kind of changes the metric quite a bit. So what happened? So the switch got flipped in March, and the first thing that happened was we started getting a lot more calls. And understanding that we have a limited number of coordinators, we only have two surgeons, so they take week on, week off call. Getting a lot more calls is very disruptive. So that is a ninefold increase in the total number of kidney offers. And so we very quickly had to realize that we had to change our presets on the system so that we would not be getting calls on kidneys that we would never dream of transplanting. A kidney that's got 30 hours of cold time that's in Los Angeles that nobody else wants. I mean, that kidney is never going to work. Certainly not going to work by the time it gets here, having traveled cross country. And so we had to change our presets, and we've cut down on the number of calls to some extent. It is still putting a lot of stress on our coordinators. However, we're learning how to manage it better. We were all very concerned that this policy, this change, was going to lead to an enormous sucking sound as kidneys from New England, particularly northern New England, flowed down to New York, where median waiting times are in the region of 7 years for a deceased donor kidney, as compared to about 4 years for kidneys throughout the rest of New England. So what happened? So it turns out that the New York programs are incredibly conservative. And there's a lot of kidneys that are procured there that we're happy to transplant, but they're not happy to transplant. And so, and this really blew me away when I started to look at this. We have actually, in the last 6 months, done as many deceased donor kidneys in 2021 as we did in all of 2020. So we'll see if this is sustained. Our surgeons are aggressive about pursuing kidneys, and I know for those of you who spent a little time on the transplant service, you know, when rounds are disrupted because we get an organ offer, we have to respond within a short period of time. But it has actually been a net benefit for us, at least so far. So, but we do still need to cut down on the organ offers to make sure that we are not getting called at 4 a.m. for kidneys that we're never going to accept. The other big thing that's happened from a policy perspective is that the prior administration directed Health and Human Services to relook at health expenditure on end-stage renal disease. And the observation that has been made on many occasions is that we are spending in this country as much on ESRD management, most of which goes to dialysis, as we're spending on NIH, Department of Homeland Security, and NASA combined. Or another way of thinking about it is about 6% of the Medicare budget just goes to managing end-stage renal disease, which is absolutely extraordinary. And so as of July of 2019, the Office of the President mandated HHS to develop policy to reduce the number of people who are developing kidney failure, to promote awareness, to incentivize preventative medicine, and to reduce the number of patients getting outpatient dialysis by 80%. Excuse me. And they wanted to do this by promoting home dialysis and kidney transplantation, and in parallel, make more kidneys available for transplantation. 80% reduction in the number of patients getting dialysis. That is amazing. Probably not achievable, but it is both goal. Excuse me. Clinically, why do we care about this policy stuff, for want of a better word? Well, we know that the number of people developing end-stage renal disease is increasing. We know that the number of people being added to the waiting list every year is going up over time. So if you look at this, this is 2008 through 2020, and you can see that the number of new additions to the waiting list is continuing to rise. And the total number of people on the waiting list for, this is just for kidneys, is now significantly over 100,000. So that's an issue. And in parallel, we're only transplanting about a fifth of those every year. So there's this huge gap between supply and demand. The drivers of this activity should not be a surprise to anybody in this room. They're the drivers that lead to chronic kidney disease in the general population. And if you look here, you can see that the biggest driver is type 2 diabetes. Hypertension has actually sort of plateaued. And you can see that conditions like chronic glomerulonephritis have remained steady. And cystic disease, and really we're talking about polycystic kidney disease, continues to be about 10% of patients who need kidney transplantation, not just in this country, but around the entire planet. So remember, polycystic kidney disease is autosomal dominant. There's no particular racial predisposition. And so we see the same number of people needing dialysis or transplant in Asia and Europe and other continents due to PKD. And of course, the other point to make is that as we look at the age of these individuals, it is the older age groups that are really contributing to the increased demand. So people over the age of 50 to 64, which is the pink line you can see here, and then people over the ages of 65. We don't really have an age cutoff for transplantation. The oldest person we've ever transplanted was 84. This is an individual who, you know, really had no other comorbidities and did extremely well. But of course, as we age, we tend to accumulate comorbidities that are going to impact transplant outcomes or likelihood of transplantation. And so what I showed in this slide are the drivers that lead to kidney listing. And then on this slide, it's basically the same sort of data, but now looking at the drivers of people who are actually getting transplantation. And it's the same drivers, okay? So it's diabetes, it's older age, it's hypertension. So these are the people that we are actually transplanting. It's a very different population of people as compared to when I was a fellow, which wasn't that long ago. And, you know, it's a much higher risk population that is much more consuming of resources, both in terms of getting them ready for transplants and then post-transplant care and management. Right now, we have reached a point where living donation over the last decade and a half, has really kind of reached a plateau. There was a brief point around 2010 where half of the kidney transplants in the United States came from living donors. And after various financial crashes, which clearly had an impact on people's ability to donate, that number has really stabilized, just starting to pick up again through kidney paired donation initiatives that I'll talk about in a minute. But the big driver over time has been the growth in deceased donation. And so there are more people donating kidneys, and more of those kidneys are being used. So we are making progress. We are transplanting more people, but we were just not keeping up with demand. I mentioned the Kidney Donor Profile Index. That's that numeric score of kidney quality. A low number is good, a high number is bad. More people are understanding that, you know, if you're 70 and you need a transplant, sure, it'd be great to get a kidney from a 20-year-old, but realistically, if you don't have any living donors, and you're going to be waiting for 5, 6, 7 years, then who knows in that period of time, well, first off, your mortality, if you're on dialysis, is at least 20% per year. Plus, you know, in that time, you may have had your stroke or your heart attack or whatever other major adverse cardiovascular event. Of course, it could be an oncologic event, but most of the morbidity in this group is driven by atherosclerotic disease. And so the chance that you're going to be ready for a transplant in due course is going to be pretty low. And so people are now more willing to accept these higher risk kidneys than they have been in the past, although it's still making, thank you very much, it is still a fairly small proportion of those kidneys that are transplanted. And as mentioned, those higher KDPI kidneys, they are not as durable. Looking at about a 15% one-year graft failure rate compared with a 2 or 3% one-year graft failure rate. Although if they work, they tend not to be as durable. But if you're, again, going back to the example, if you're 70, you get a kidney from a 65-year-old, that's a big upgrade, and it still beats the heck out of dialysis. We now have ability also to transplant hepatitis C positive kidneys into hepatitis C negative recipients. This we could never do until we had highly effective antiviral therapies available to us. This is kind of a niche initiative currently, but there is capacity for this to grow. And importantly, hep C positive donors, of course, are being driven by the narcotic epidemic. And a lot of those kidneys historically were discarded. We have transplanted here hep C positive kidneys to hep C negative recipients. And ideally, just treat them after they get their transplant. Because of course, if an individual agrees to get one of these kidneys, then they could potentially be looking at a much reduced waiting time. Still a niche activity. This is fairly new. But it is kind of here at the same time. We're working on protocols to really help this grow locally. HIV positive kidneys were not transplantable until the Obama administration changed federal law. At that time, until that time, it was a felony to transplant a HIV-positive kidney. Now we can transplant HIV-positive kidneys to HIV-positive recipients under the aegis of a research program. That was called the HOPE Act. Again, very tiny numbers. But the point is that transplant programs are always looking for ways to expand the numbers of transplants that are happening. In terms of living donation, I mentioned that living donation took a hit because of the various financial crises, numbers went down. The other observation is that if an individual has a potential living donor, there's about a 30% chance that the donor will be incompatible with the recipient, either because of ABO mismatches or because they are sensitized and have anti-donor antibodies. And historically, that was a hard stop. There was no way to get beyond this. Various approaches to incompatible transplantation have been developed, one of which was the use of desensitization. So some combination of plasmapheresis, IVIG, immunosuppression before transplantation, either to remove anti-HLA antibodies or to remove anti-A or anti-B antibodies, and then do transplantation. The problem is it's expensive, it's not reimbursed, high incidence of infections, doesn't always work, and long-term outcomes, at least for HLA incompatible recipients, is less, mostly because of the higher incidence of antibody-mediated rejection, leading to premature graft failure. And so the question is, can we find swap donors? So the idea being that if I need to give a kidney to Dr. Guerin, but we're not compatible, then, well, maybe I could give a kidney to somebody else, or they could give to Tom, and Tom could get a kidney back. So this whole idea of kidney pair donation. We've had local initiatives here and elsewhere for decades, which have had some success. What's really spurred kidney pair donation is the development of large national networks. We're part of one called the National Kidney Registry, which is by far the most successful. And NKR is now making up about 17% of all living donor transplants in the United States. And you can see the numbers here. So very impressive numbers, 5,000 kidneys, usually as part of a chain. There are some other advantages to the National Kidney Registry. They do provide the donor with what they refer to as donor shield, which is health insurance for a period of time. They've got this automated donor sign-up process called DASH that allows people to log on to our website and put in their information. And very often we can screen fail people without using up coordinator time. If somebody's already got diabetes or hypertension, then obviously they are better served by not being a kidney donor. And the other thing that's happened is this concept of a voucher donor, which is kind of fascinating. So if a grandparent knows that their grandson has polycystic kidney disease, well, perhaps they could donate a kidney to NKR in order to provide their family member with a voucher to be redeemed for a living donor kidney at a later time. It's a very interesting idea. And so this idea has taken hold and has really become a big thing, so that we now have more living donors coming into the system. And we do have people who are redeeming the numbers of these sort of voucher donors, but voucher kidneys, but it's a smaller number than the people who are donating. So there's a real net benefit to the entire system. And the waiting time for these kidneys has gone down over time. So a lot of innovation in the field of organ, organ allocation, in deceased donors, much broader view of what is a suitable deceased donor, and a lot of innovation happening in the field of living donation. And I will say that within our group, we have a living donor team whose job it is to stay continuously connected with NKR. There's a huge amount of work that goes into each one of these swap donors, probably about 3 to 4 times the amount of coordinator time as it takes to work up a standard compatible living donor that we're going to transplant here without any swaps involved. In terms of immunosuppression, things have pretty much stabilized where most programs are using antibody induction therapy. That's the top graph on the right. I remind myself that while we're now looking at rejection rates within the first year that are consistently less than 10%, it was not always so. And certainly when I was a fellow, we were looking at rejection rates in the mid-90s of approximately 40 or 50% within the first year post-transplant. Most of these rejections were treatable, but they do have an impact on long-term outcomes. And they're not always treatable. And so, you know, we would occasionally lose kidneys from rejection. Very unusual for us to lose kidneys from at least early rejections nowadays. So this is where we were. This is kind of where we are. So part of the improvement has been the more widespread use of antibody induction therapy. Really, in the United States right now, we are 3 drugs that are used. We use thymoglobulin, Campath is another option, basiliximab is another option, but we mostly use thymo. And, you know, when I had a slide on immunosuppression 10, 15 years ago, we had sort of a wide variety of drugs which we hardly ever use anymore. For example, the mTOR inhibitors, sirolimus and everolimus. Sirolimus was approved in 1999. It is hardly ever used anymore because it associates with worse outcomes and more side effects, in a nutshell. Most programs are now using a protocol that includes tacrolimus, mycophenolate, and most programs, in spite of whatever advertising they do, those programs are also using steroids, admittedly low-dose steroids as part of their maintenance protocol. And that's really what this graph shows. So most it's TACM and that steroid. Big urban centers like to advertise that they do steroid-free immunosuppression. And they do to some extent, although we do know that if you take people off steroids after transplant, rejection rates go up. Recurrence rates for things like IgA nephropathy also go up. So it's not necessarily a zero-sum game. Our own experience with thymo, there's a paper that we wrote a few years ago. You know, we've been using thymo for close on 20 years. And, you know, we've had great outcomes. We've developed an iteratively developed quality process to look at dosing, because this drug is expensive. And so we've come up with a protocol that uses substantially less thymoglobulin compared with other programs. And that has resulted really in pretty remarkable cost savings. It also allowed us to lower our length of stay and utilization rates. But the cost savings, literally of millions of dollars a year, is always welcome in environments where healthcare expenditure is running away from us. This is where we are right now with rejection rates. So all comers, so it's less than 10%. Our rejection rate last year we had 4% rejection rate here. The year before we had 0 rejections in adults. And so that's kind of the situation. Rejections, by the way, are usually asymptomatic. People are taking their immunosuppressive medications. So the classic things that were described in textbooks, fever and graft pain and hematuria, really you see those in people who are just not taking their meds, or in people who've come off their immunosuppressive medications after their transplant has failed. So rejection is less of an issue, quite frankly, and that probably has an impact. We do have a new tool in our toolbox. Historically, we look for allograft well-being by looking at things that you're familiar with, creatinines, urine proteins. For 15 years or more, we've been able to look at donor-specific antibody testing as a screening test for either acute or chronic antibody-mediated rejection. Of course, rejection can occur also by T cells, and one of the newest assays that we have available is this donor-derived cell-free DNA. There's a couple of different companies doing this. You do a blood test, and you get a result back. And with very impressive performance characteristics, negative predictive value, 96%, that's kind of probably as good as you're going to get. And basically, the idea is that you send the blood test off. If all is well, the amount of donor cell-free DNA in the circulation is going to be less than 1%. And if you see a big uptick, as is exampled by this graph, then you'd be very worried about the probability of rejection, either a T-cell mediated rejection or a B-cell mediated rejection. And so we've been using this. The local one that we're using is called AlloSure, but there are others now for probably a year and a half. And it actually has tipped us off to probability of badness. But we're also learning that it can be a very reassuring assay when we have somebody who's got a transplant and the kidney is not performing as well as we would have anticipated. And one of the questions always is, is this rejection? So sort of too little immunosuppression, or in fact, is this toxicity? In other words, too much immunosuppression or too much of the wrong type of immunosuppression for this particular kidney. And so we're increasingly able to make a decision that, we're looking at calcineurin nephrotoxicity and potentially avoid the need for an allograft biopsy. And then in turn, we can decide, well, do we just simply run the levels lower, or do we switch them to something else? And so that's been a recent advance, which we haven't done a deep dive on in terms of quality as yet, but I think it's very interesting, and it's definitely here to stay. I did want to mention one of the newer immunosuppressive drugs. So belatacept is a biologic agent, works clearly differently from all of the other oral immunosuppressive agents, which basically are small molecules that get into cells and interfere with cellular machinery, whether it's tacrolimus binding to the FK binding proteins or cyclosporin, which binds to cyclophilin, et cetera, et cetera. So belatacept is a first-in-class monoclonal antibody. I started working on a predecessor of this in the immunogenetics lab at the Brigham in 1995, with an agent called CTLA4IG. Basically, it's a co-stimulatory blocker. It interferes with the second signal of T-cell activation. And so it's been approved for use in kidney transplantation since 2011. Still a small part of what we do. It's parenteral. It's more expensive. It has to be given to people who are Epstein-Barr virus positive, because in the initial trial, the two trials, BENEFIT and BENEFIT-EXT, there was a signal that perhaps people who are Epstein-Barr virus naive may be at higher risk of developing lymphoma if they're put on this drug. We were part of a registry called the MORE Consortium, which didn't really confirm that, but nonetheless, this drug is not approved for people who are Epstein-Barr naive. Not a big issue. 95% of adults are EBV positive, having had mono at some point, presumably in their teenage or young adult years. It's approved for kidney only. There was a clinical trial in liver transplant, which yielded very surprising adverse results. And in general terms, livers are easier to immunosuppress than kidneys. But in the trial, the randomized trial looking at belatacept in livers versus calcineurin inhibitor therapy, and the rejection rates were higher, the graft failure rates were higher, and there was a small higher mortality risk associated. And so that trial was stopped prematurely, and that actually prevented any other studies of belatacept in non-kidney solid organ transplants. We're tending to use this drug selectively, really for one of two reasons, either because of disabling neurotoxicity associated with calcineurin inhibitors, so headaches, tremors that are so severe that people can't eat or function. That's one major reason. The other, of course, is nephrotoxicity. And I mentioned, some kidneys are just inherently more susceptible to any amount of calcineurin inhibitors. In its most severe manifestation, we can see thrombotic angiopathies, but the hemodynamic component can be huge. And so in switching people from belatacept to tacro, other way around. In switching people from tacro to belatacept, we can really make a lot of these issues go away, although the patient then needs to go to an infusion center once a month, and sometimes IVs can be a problem, sometimes they can need Mediports. But it really is a great option for people. The graph here shows the 7-year follow-up of one of the initial studies that was called Benefit. This was a randomized trial of patients, standard risk patients, either living or deceased donors. It was comparing belatacept with cyclosporin, which is fine. Cyclosporin and tacro, we tend to use tacro more because it's easier to use, but cyclosporin and tacro will provide the same long-term patient and graft survival outcome benefits. And so what was shown at 1 year was that patient and graft survival was the same. At 3 years, patient and graft survival was the same. At 5 years, patient and graft survival were the same. At 7 years, we're now seeing the belatacept pulling ahead, and those grafts are now lasting longer because you are mitigating the continuous nephrotoxic potential of the calcineurin inhibitors. And so this is a good option, both in terms of adverse effects and potentially also in terms of longer-term outcomes. And in general terms, when we go back to the Scientific Registry of Transplant Recipients, there's an annual report that's published every year. You can access it. It's published as part of the American Journal of Transplantation. It's an addendum to the AGT. And you can see that overall graft failure rates after transplantation have declined over time. And that's true if you look at it at 6 months, 1 year, 3 years, 5 years, or 10 years. Another way of thinking about this is that the median survival, or the half-life of deceased donor transplants 10 or 15 years ago was about 7 years, which isn't all that long. We're now looking at median survivals of about 9 or 10 years. Living donors always do better, and better matched living donor kidneys do best of all, so that were you to be fortunate to receive a zero antigen mismatched kidney from your sibling, then you're looking at median survival rates of 20, 25 years. But the concept of a kidney for life, unfortunately for most people, is elusive. May not be a big deal for you if you're 65 or 70, but of course, if you're a child or a young adult and you're looking at a median survival of, 10 to 20 years, then almost certainly at some point you're going to need another transplant. We actually are evaluating a woman right now who got her first kidney transplant in 1980, and that kidney pooped out after 36, 37 years. She got on dialysis for a couple of years, and we just retransplanted her. So to make the point that, one kidney for life is not usually going to be the experience for many individuals. The other thing that I think is encouraging is that as compared to the previous graph that just looks at graft failure, so the kidney fails but the patient lives, if we look at death-censored graft survival, we've actually seen even more of an improvement over time. So UNOS defines graft failure as happening when the kidney stops working, patient starts dialysis, or if the patient dies. And in fact, death with a functioning graft is the most common cause of graft failure per UNOS definitions. So it is very encouraging. This is really encouraging for me to see that not only are more kidneys lasting longer, but the mortality rate has gone down over time. So really very, very encouraging. Why is that? Well, I think, we've had advances in immunosuppression, but we've also had at least some advances in terms of recognizing and being much more aggressive at managing atherosclerotic cardiovascular disease complications. Which leads me to this section. So I'm going to focus a little bit on infections here. COVID has impacted everybody's life enormously. We know that COVID can get into the kidney. These are micrographs showing COVID interstitial nephritis. This is an electron micrograph showing COVID in a kidney tubule. This was a post-mortem series that came out of Wuhan very early on. We know that COVID can cause hematuria. We know COVID can cause proteinuria. And these are independent predictors of bad outcome for patients hospitalized with COVID. So it's not all ATN. There's this COVID interstitial nephritis. And so as a nephrologist, we look for the blood in the urine, we look for the protein in the urine, understanding that potential time course for recovery or not recovery is going to be very different with somebody with ATN versus an interstitial nephritis caused by this scary virus. We very rapidly learned that COVID in transplant recipients is bad. It's also bad in people who are on dialysis. And so news coming out of New York, news coming out of Spain showed very similar mortality rates. So about 30% mortality for transplant recipients who contract COVID. Higher risk in people who are older, of course, but still high risk across the board. Much higher risks of hospitalization, ICU admission, ventilation, dialysis. And so if these individuals end up ventilated on dialysis, then their outcomes are particularly poor, which again should not be surprising to this group. Similar results got from various other programs. There's a whole bunch of single center series shown about a 30% mortality. And by the way, the mortality for dialysis patients who contract COVID is about the same. It's about 30%. So these patients are not necessarily disadvantaged by virtue of the fact they're immunosuppressed, but they are as disadvantaged as people who are on dialysis. So COVID in this population is bad. We've been tracking our COVID experience, and you can't read the table there, and that's okay. This is sort of a table that we've been maintaining, extracting data from EPIC, kind of feeds into our quality initiatives. We're following about 800 transplant recipients here in the greater Portland area. And by the way, we have about 1,000 dialysis patients here in the state of Maine throughout the entire state. So, we have almost equivalent numbers of prevalent transplant recipients as we have dialysis recipients. So of these patients, and I know all of them, so of these, 45 of our patients have had COVID so far. Of those, 20 were hospitalized. We've had 5 deaths. We've had a number of people who've ended up with refractory respiratory failure, and care was withdrawn, ventilation was stopped. We had one person who died of a stroke a couple of days after being discharged from the hospital. We had another individual who had a rapid progression of their pre-existing dementia, probably triggered by COVID. And so we've had 5 deaths. Not as widely reported. There's been a lot of other things that we've seen. We've had one person who lost their transplant function, ended up, is now on dialysis. We've had concurrent bacteremias. We had a person with a perforated duodenal ulcer. We've seen, starting to see some signal of an uptick in other concurrent infections like C and B and BK virus. The good news is that we're seeing less of this with the widespread implementation of vaccination. And in fact, the last person we had who died of COVID post-transplant here was an individual in March who had not been vaccinated. And that was in spite of our efforts to get the word out to everybody, just get the vaccine. From a program perspective, this has been incredibly time-consuming. You can imagine we have all of these people, they're educated, they're engaged, and they were anxious as heck. And so our nursing staff were fielding too numerous to count telephone calls. We've had mass mailings going out to people as information has become available, very aggressively promoting vaccination. At one point, we made a decision to shut down the program for new transplants until we got the information that we know that these people do about the same as people on dialysis. So when we shut down in March, we opened back up again in June. And we ended up doing a lot of transplants last year. As everybody else did, we moved a lot of our patient encounters online. We moved our pre-transplant education fully online. That's been a crowd pleaser. We've had so many questions about when can we get the vaccine? Why aren't we being prioritized for the vaccine? And now we're getting the questions, should we get the booster? That got kind of the third dose. So that question has now been answered. Should we get the antibody test? And of course, some people have gone ahead and got an antibody test post-vaccination. And it showed, of course, that, as has been demonstrated, that the seroconversion rate after 2 doses of the mRNA vaccines is a lot lower in people who are immunosuppressed, which is not a surprise. 54% of immunosuppressed transplant recipients studied at Hopkins made antibody, plus those who made antibody had lesser antibody than those people who are not immunosuppressed. By the way, dialysis patients respond fine to the vaccine, so they have similar seroconversion rates. A lot of interventions culminating now that we have at least one of the mRNA vaccines is approved. We're now at a point where we actually are going to be implementing a policy to require COVID vaccination prior to transplantation starting next month. We already know that some programs have run afoul of the press. You can imagine somebody who's an anti-vaxxer, and the transplant program is now, instead of being their hero, is being the ogre for not going ahead with transplantation because somebody's not vaccinated. But I think the data is pretty compelling. You get COVID post-transplant, you got a 1 in 3 chance of dying. Get a vaccine, it's not a problem. I mean, to me, it's a risk-benefit ratio that's a no-brainer. Another virus that I sort of briefly mentioned is BK polyomavirus. Again, these are DNA viruses that are endemic in the population. This has been a problem for us starting about 20 years ago as we had access to more effective immunosuppression. We can set up a viral tubulointerstitial nephritis. We see viruria in about 40% of our transplant recipients. We see viremia in about 10%, and we see BK virus allograft nephropathy. So we do a biopsy, we see lots of cells. We can stain them for the BK virus. And that's still a problem because BK virus, we don't have any specific treatments for it. Fortunately, we've learned over time that we can screen for this, and before patients develop nephropathy, we can cut back on immunosuppression. And usually, for about 80% of people, that's all you need to do, and the virus goes away. But there are a subset of people for whom that is not sufficient, and occasionally we will still have progressive slow loss of kidney function for people with this condition, although very much less than we had in the past. We don't have, we have no specific interventions for this, and so interventions that similar to for coronavirus, we're not using hydroxychloroquine anymore. We shouldn't be using ivermectin. In BK virus, we're not using quinolone antibiotics. We're not using IVIG. We're not using leflunomide. There's a whole bunch of other, potential treatments that just didn't pan out. And so the only treatment we have is a crude tool, but the one treatment we do have is to cut back on immunosuppression. The other big group of viruses that we worry about are the human herpes virus family. So we're all familiar with HHV 1 through 8. In my world, the one I worry about most is CMV, and CMV is still a bad actor. We know that people who are donor positive, recipient negative are at highest risk. And we prophylax individuals to prevent them from developing tissue invasive disease, and we're mostly successful at doing that. Although when we prophylax, we do put people at risk of viral resistance. There are some newer antiviral drugs that are in development. Marabavir is one. There was a CMV vaccine study that we participated in, which supported the null hypothesis. It basically didn't work. And so CMV continues to be a problem in our world. And I happen to know that the cardiology service has recently had an inpatient heart transplant recipient in the hospital with drug-resistant CMV, and now we're getting into really difficult therapeutic options, drugs like foscarnet and so forth. So CMV continues to be a problem, generally manageable, but again, not always manageable. One of the other things that I was happy to see is that the incidence of new onset diabetes has been coming down over time. I think that parallels reduction in steroid dosing that's been happening across the country. So we know that risk factors for new onset diabetes are things like obesity and family history, but also specific to transplant conditions like polycystic kidney disease, which we said makes up 10% of our patients. Hepatitis C is a big risk factor, and tacrolimus. But it's nice to see that over time the incidence has gone down. There is still a differential, so people with higher BMIs are at more risk than people with lower BMIs of developing new onset diabetes. So back to us, we did 45 kidneys last year, which was close to what we had budgeted. Actually more than twice as many were living donor transplants. We have seen an increased number of referrals for transplantation over time, as mentioned. We had over 1,300 people apply to us for consideration of living donor transplantation. So that number has increased over time. Our patient and graft survival rates are excellent, and our utilization rates, our admission rates are about half that of the reported to the SRTR. This is our living donor program. Just very quickly, the number of our transplants who are going to people who are not on dialysis is extremely robust. Last year, it was about 30%. This year to date, it's about 40%. A national average is about 15%. Clearly, if you can preemptively transplant somebody, you can completely obviate the need for access and all the complications that occur from dialysis. So I think this is a quality metric that I'm particularly proud of. We do have a whole bunch of quality initiatives over the last year in spite of COVID and all the other things we're dealing with. We moved our class online. We've got electronic consents for transplantation. We revamped our social work assessment tool. We finally have built a bridge between EPIC and UNET, which we need to do for data reporting, mandatory data reporting for every transplant patient. And then we have what we refer to as developed a readiness model. We'll skip that. So I mentioned our referrals have increased, and this is without having any increase in the number of staff who can handle this. And this really put us behind the eight ball because it was taking us too long to evaluate people using our standard model. And so we partnered with the CPI to develop this really big quality project to kind of go back to the very beginning and think about how we lower barriers to getting people waitlisted for transplantation. And without going through all of the details, and this has been a many month project involving our entire team, we reimagined things so that instead of doing a whole bunch of testing in order to get people listed, we would list people using lower criteria or less stringent criteria, and then defer testing until people are just about ready to get a transplant. So whether they're coming to the top of the list, deceased donor list, or they have a living donor. And so we've had really quite remarkable success. We've increased the number of people who are being evaluated. We're getting them through the evaluation process much more rapidly. We've doubled the size of our waiting list. And this is our time from listing to decision. So you can see we've had a huge positive impact on this important pre-transplant process. And very quickly, we do have a very robust quality program. I've got a quality manager. We track all sorts of things in a lot of detail and have opportunity to really get into the weeds on topics that we care about. I mentioned things like CMV and BK and so forth, but there are other things that we care about, like delayed graft function, surgical complications. And we've got a very robust method for tracking all of these things. I'm very grateful that we've got a team that's, highly educated, highly engaged, and this is not me. This is the team is really a remarkable group of individuals. So I'm just about out of time, so I will actually leave it at that, and I'll be happy to take any questions.
Thank you very much. Thank you, Dr. Vella. It was really a great mix of clinical medicine, basic science, policy, quality improvement. It's really waiting for your talk. So why don't we start with questions from the live audience, and I'll just remind you to repeat the questions for the Zoom audience if you can. So any questions in this crowd?
There were some questions on the chat room. What percentage of post-transplant patients are able to completely come off immunosuppressive medications, and how would you decide on that? Yeah, so we don't generally take people off immunosuppression. There are a couple of examples where we could. We transplanted an individual who had received a bone marrow transplant from his brother for childhood leukemia about 10 years ago, and it was a very interesting workup, but basically we transplanted him without any immunosuppression. So that was one example. We did have another example of a sibling-to-sibling. These were twins. They didn't look like each other. The twin who had kidney disease turned out he was genotypically identical to his brother, but he looked different because he'd had kidney disease all his life, and he was a lot smaller. So that was another example where we were able to do transplant without immunosuppression. And otherwise, the experience of people coming off immunotherapy completely is that they reject. And every program usually has one or two patients who come off immunosuppression having done the experiment themselves, but almost always they are going to come a cropper and the kidney is going to fail. But every now and again, you'll find somebody who's out there who is operationally tolerant for reasons that are very difficult to understand. There's been an NIH group trying to study these people, but they're kind of hard to get because these are people who have dropped off the face of the earth. So trying to actually study them is nearly impossible. And then for Pete, there's a question here about islet transplants. Where are we with islet transplants? Islet transplants are very interesting, they're experimental, and they don't really work in the real world. The problem is you need the islets from about 3 pancreases in order to make somebody euglycemic. And the issue is they still need immunosuppression, they still get a lot of nephrotoxicity, and the euglycemia is not usually maintained, so there's a high rate of failure. In terms of whole organ pancreas transplantation, that's a field that, in essence, is dying. And again, for reasons of high incidence of surgical complications and lesser long-term pancreatic allograft viability. So clinical islets, experimental only, clinical transplantation is dying. We actually had a pancreas program here. We closed it down. We didn't have enough numbers. And of course, now with Dexcoms and insulin pumps, it becomes less of an issue anyway. And then there's another question about changes in KDPI, and does that impact delayed graft function? Of course it does, yeah. So, because one of the things we've been, so if we use higher risk kidneys, then we expect that more of those kidneys are going to be slow to start, and there'll be a higher incidence of need for dialysis after transplant. And are we seeing that? Yeah, we are. Well, we deal with it. And most of those kidneys are going to work. Usually the kidney will open up within about a week of the transplant. Occasionally we have somebody who's on dialysis for a couple of months. That's really uncommon, but we had one of those within the last year also. I think that's the last of the questions online. Oh.
A compliment, Dr. Buck.
Thank you, Jonathan.
Okay, well, thank you very much at the end of our hour, and end of the summer series.